Start today's session on breast cancer with the first talk by Dr. Akhil.
Yeah.
Dr. Akhil Kapoor is the HOD and Professor of Medical Oncology in Tata Memorial Hospital, Varanasi. Dr. Akhil, please take over.
Thank you. Thank you, Dr. Amit and Dr. Saritika, for giving this opportunity and arranging this very well-planned sessions. When I saw the sessions, it was so beautifully arranged. It seems that we are covering so many things in so less time. So it's a very good opportunity for our residents and young colleagues to get an entire information knowledge. So without further delay, I would like to start my talk, and I will focus on first line decision making in patients with hormone receptor positive, HER2 negative advanced breast cancers. So this is a very important point that hormone receptor positive advanced breast cancers, they are very important, and they do form a significant proportion of our advanced breast cancers. Thankfully, we have good treatment options where we can utilize multiple hormonal therapies before going into ADCs, chemotherapies, and other treatment options which are more toxic. So always patients wants a good disease control without impacting quality of life, that is deterioration in quality of life. We know that yes, there are some important points, including visceral metastasis, which help us to know the disease biology. Sometimes we see, despite hormone receptor positive disease, patients having liver metastasis, patient having brain metastasis, though are not very common, but still we see those. Also, prior treatment response in advanced settings is very important, including prior treatment in adjuvant settings and all. So that needs to be taken care. So these are the ESMO guidelines, which will be very helpful. If the patient is having ER positive, HER2 negative metastatic breast cancer, CDK4/6 inhibitor plus endocrine therapy are the treatment of choice. Even with patient with visceral crisis, previously chemotherapy was considered, but now there is enough data from multiple studies that even with patient with visceral crisis, chemotherapy is not mandatory. We can start hormonal therapy with CDK4/6 inhibitor. But if CDK4/6 inhibitor is not feasible, then go ahead with chemotherapy. So that is the present paradigm. Also, when the patients progress on these treatment options, we must understand there are multiple other options, including multiple other targeted therapies and hormonal therapies as well. So there are now second line targeted therapies and hormonal therapies which are coming up, besides the standard BRCA1 and BRCA2 testing, which we all know is a very good option. And is besides BRCA1 and BRCA2, germline palbo2 is also a indication for utilizing olaparib in this setting. If there is no risk of organ failure, the options include fulvestrant, CDK4/6 inhibitors. Other options include everolimus exemestane or everolimus fulvestrant, fulvestrant alpelisib, or now capivasertib is also going to be available very shortly, and we have utilized it as a part of multiple trials. Capivasertib through CAPI 291 study is already approved for PIK3CA mTOR mutant pathway. PARP inhibitors, as I have already highlighted in the previous points. So yes, chemotherapy is utilized only after the other treatment options are exhausted. We tend to utilize multiple other settings as well. So these are the important data sets which are evolved over time. These are three drugs which we have seen: Monalisa 2, Rebo plus Letro, Palomar 2 with the palbociclib and Monarch 3 with abemaciclib. This is what you need to see and understand. Hazard ratios for ASCO cutoff is median OS improvement is around 20%. That would be clinical meaningful in patients with breast cancer. If you see, it is palbociclib is unable to cross that, and that is negative, and that cutoff is being crossed by Rebo mainly. Abemaciclib is also just touching it, but not able to cross that. But yes, the thankful part, Monalisa 2 is able to achieve that significance ratio, and with hazard ratio of 0.76, where that is West Point. If this we have discussed, ABC guidelines suggest that aim of any treatment for a patient with advanced breast cancer must be that it should not add only quality of life, quantity of life, but also quantity of life, allowing the patient to build and achieve life projects. The consensus patient perspective should be included, and we always try to include patient's perspective. And while extended survival is the main treatment goal for both clinicians, but OS is most of the time secondary endpoint in trials. which is definitely misleading for surrogate PFS. So most of the time, PFS is not considered an appropriate surrogate for OS in advanced breast cancer. These are the known shortcomings which we have discussed previously. Rebo is the only CDK4/6 inhibitor presently which have demonstrated significant OS benefit, regardless of combination partner or menopausal status. That is very important point. So we have seen data sets where premenopausal data is not so good for many of the TKIs and CDK4/6 inhibitors. While the good part is that with Monalisa trials, we have good data sets for both premenopausal and postmenopausal. Let's see some differences in mechanism of action for CDK4/6 inhibitors. We classify them as CDK4 and 6, but important is to note that CDK4 is more important inhibition for AR positive breast cancer. CDK6 is a part which is there in bone marrow, leading to myelosuppression, and CDK9 is present more so in GI tract, leading to more of diarrhea when inhibited. So that is the important point. CDK4 inhibition is most important. If we, if we see the on target and off target activities with Rebo, what is most important point? CDK4 inhibition is strongest, while Palbo, it is inhibiting both CDK4 and CDK6 also strongly. Abema, it inhibits CDK4, CDK6, and CDK9, all three, leading to more amount of diarrhea. That is the off target activity of Abema, leading to more amount of diarrhea, which is not there with other two drugs, while Palbo leading to more inhibition of CDK6, leading to more amount of myelosuppression. So that is the important part. Now, free drug availability is also very important. How a drug can interact with its target, that is also very important. You can see free drug exposure, that is 22 times than normalized to palbociclib with Rebo. That means that this seems to be directly most useful drug in terms of inhibition of CDK4. Also, if we see the NCCN guidelines, category 1 recommendation, EI plus CDK4, there you can see ribociclib. Fulvestrant plus CDK4, you can see ribociclib. So it is very clear that most of the time, the category 1 recommendation is there for ribociclib. And high ESMO MCBC scores reflect the positive benefit treatment with Rebo regardless of endocrine therapy or menopausal status. This is what I've already highlighted, and this is through Monalisa 2, 3, and 7 series. All these three trials have recruited both postmenopausal, premenopausal also, and pre and perimenopausal were also included in part of Abema trial. So yes, the good part is that in both pre and postmenopausal, regardless of the partner, AI or fulvestrant, the drug is there and it is approved. Also, the guidelines, as we discussed, ABC guidelines also says the same. The right choice trial has already demonstrated that OS benefit is there for with Rebo. That is why it is most preferred CDK4/6 inhibitor as per the ABC 67 guidelines. So let's come to the quality of life and safety profile data as well. If we see, this is the summary of the quality of life data from various trial. If again seeing that maintain health related quality of life data for Monarch 2, 3 is there. It also there for Monalisa trial, but yes, with Paloma trial it is not available. And also we must understand that increased worsening of diarrhea scores is seen with a lot of trials related to abemaciclib, which is another problem, which is very important to take care and consideration. GI adverse effects with Abema may be result of higher off-target CDK9 inhibition, which we have already covered, and that leads to a significant amount of discontinuation in some of our patients receiving Abema. While Rebo, we need to be just aware of the most important toxicity, QTC prolongation. So be careful about the drugs which are concurrently being administered. Sometimes some anti-epileptic drugs, sometimes some other drugs, which psychiatry drugs, which might lead to QTC prolongation. Also, sometimes patients who had some amount of diarrhea due to any cause have low potassium, leading to significant QTC prolongation. So all these 3 points need to be taken consideration so that there is no significant QT prolongation, and that leads to best possible outcomes. And without any discontinuation or any break, you can continue Rebo. This is another analysis, matched pair analysis for quality of life data for first line Abema and Rebo in combination with AI. So if you see the data sets, they are quite similar in terms of inclusion, but it is very, when you see the matched data set and weighted analysis, the baseline characteristics match those of patients in the corresponding Abema and placebo arms in Monarch 3. And it is very clear that by weighing this data, you feel that patients have a significant selection benefit in this Mona Lisa trial. If also see, the most important part from this data analysis is that if you do quality of analysis, it will be favoring first line Ribo with NSAIs versus Abema with NSAIs in post-menopausal patients. So that is an important point. And in older patients, specifically above 55 to 60 years in our country, we need to be very careful about diarrhea, because these patients tend to discontinue the treatment if they develop significant toxicity. So that is need to be taken care into account. And also, as a time to chemotherapy is a very important outcome in hormone receptor positive breast cancer. We need to take care of the same. Data sets have clearly suggested that chemotherapy will have negative quality of life, and we want to delay deterioration in quality of life as much as possible till it is feasible. And these data sets are very important. Again, neutropenia, as we discussed, most of the time, the CDK6 inhibition is causing more amount of myelosuppression, which is there, and we need to take care of the same. Good part with Rebo is that, again, it is inhibiting CDK4 predominantly, not CDK6, leading to better outcomes and less amount of neutropenia and thrombocytopenia. The right choice data also suggested that Rebo plus endocrine therapy resulted in somewhat higher grades of grade 3-4 neutropenia versus combination chemotherapy. But at the same time, grade 3, grade 4 febrile neutropenia were not reported very less, that is 0% versus 3% in combination chemotherapy. So grade 3, grade 4 febrile neutropenia unlikely to be occurring with ribociclib. This is what we have seen and already have significant experience. Coming to the special population of older patients, that is elderly. If you see this example, 76-year-old retired teacher and a grandmother, hormone receptor positive disease, endocrine therapy positive for 5 years, presenting with multiple bony metastasis. Patient has hypertension and diabetes, which are well controlled. Treatment goal, if we see patient fitness, drug-drug interactions, comorbidities, all these are very important. Patient who is fit should be prescribed the standard of care treatment with CDK4 plus AI. This is what we have seen, and we do geriatric clinic at our center. Dr. Vipnesh is also there, who will be giving the next talk, who is taking care of the geriatric clinic at our center. And this is very important for our patients. Enrivo plus endocrine therapy achieved consistent overall survival regardless of the patient age, in respective of less than 65, 65 to 75, or more than 75. So data is very consistent across age groups. That means the patients even above 75 are tolerating the treatment well without much toxicities. So yes, ribociclib has definitely given consistent efficacy and safety independent of the age. And there are multiple real-world data sets from Ribana and Complement 2, and the Ribana data also showed improved or maintained quality of life and consistent efficacy data sets. Also, the Complement study showed adverse effects of Ribo being similar across the age groups, which is quite different from abemaciclib and palbo, which show a significant increased toxicity in older patients, where we need to be much more careful. And if we see this data, this interim analysis of Ribana, neutropenia was again similar, 25.8%, and OS effect size in elderly patients is also similar. If you see, most of the time we see that older patients do not do so well, and that is why they are recruited less in trials. But thankfully, in this data sets, this is good. And if we see OS of elderly patients with Palbo, again, it is negative data. So yes, this is important. Coming to another important subset of visceral metastasis or aggressive disease, this is a 59-year-old lady where the patient have multiple lung and liver metastasis. The treatment goals, they are suggesting a significant OS benefit with visceral metastasis also, that is liver or patient metastasis with other sites. It is clearly showing good outcomes with visceral metastasis as well, and the safety profile is consistent across. Right choice data, which we covered, irrespective of the combination chemotherapy you give, Rebo plus NSAI plus gosylin showed better outcomes, including PFS. So there is significant benefit despite control arm to be having doublet chemotherapy. So it's very, very good, and lowest rate of symptomatic adverse effects. So improved quality of life with preserved benefit across subgroup of the patients, be it visceral metastasis, be it patients with advanced multiple sites of metastasis. So this suggests that OS benefit is also maintained, and 5-year median OS data benefit across all groups. Post progression of first line Rebo, continuing it can be an option as per the data set available to get the optimal OS survival. So these are the subscription points, and